Prostate cancer treatments in advanced stages do improve survival, however, are associated with significant cardiotoxicity. Cardiovascular disease remains a leading cause of non-cancer death among prostate cancer patients. Here, the prostate cancer therapy cardiotoxicity map systematically evaluates cardiotoxicity across 5 key domains, which are heart failure, myocarditis, vascular toxicity, hypertension, and arrhythmias. A systematic review and network meta-analysis was conducted from 13 randomized trials involving 16,000 patients. Bayesian models were also employed to estimate relative cardiotoxicity risk across therapies, accounting for prior treatment. Some relevant findings were for MHSPC, darolutamide when combined with ADT and docetaxel showed a safer profile with lower risks of hypertension and arrhythmias when compared to abiraterone acetate and prednisone. This may be attributed to the mineralocorticoid excess and prednisone dose. Hence, darolutamide in this setting may be the preferred option for minimizing cardiovascular risks, particularly for those with pre-existing hypertension or arrhythmias, despite guidelines recommending both darolutamide and abiraterone as first-line settings if docetaxel eligible. With regards to non-metastatic CRPC, ADT plus enzalutamide increased hypertension risk compared to ADT alone in combination with darolutamide or apalutamide. However, as this was an indirect estimate and differences in placebo event rates between Spartan and Prosper trials were present, these findings are uncertain. Similarly, with regards to vascular toxicity, darolutamide demonstrated a lower risk compared to ADT and enzalutamide. However, differences in placebo event rates were also present. Finally, when looking at the Bayesian analysis and MCRPC, interestingly, olaparib, when added to abiraterone and prednisone, reduced the risk of hypertension compared to abiraterone and prednisone alone. And similar to the previous setting, enzalutamide increased the vascular toxicity risk compared to abiraterone acetate-based regimens. To conclude, this systematic review has limitations, including the exclusion of commonly used drugs in clinical practice such as apalutamide and the exclusion of the Enzamet trial, inconsistent stratification of disease states across studies, and the systematic exclusion of patients with pre-existing cardiovascular conditions. Variability in placebo event rates, particularly between Aramis and Prosper, complicating comparison interpretability, and the majority of trials included were classified as low quality according to the cinema criteria. Despite these limitations, the review highlights significant variability in cardiovascular risk across therapies for advanced prostate cancer. Darolutamide consistently demonstrated a favorable cardiovascular profile in MHSPC and non-metastatic CRPC, while olaparib interestingly reduced hypertension risks in MCRPC when combined with abiraterone and prednisone. And finally, enzalutamide exhibited a higher vascular toxicity risk across all stages.